treated fibromyalgia, and then we treat the autonomic nervous system, which is present on the posterior aspects of the body between thoracic 1 right down to L2, which is lumbar 2. We also treat many persistent post-surgical pain syndromes, patients who've had mastectomy and or reconstruction, and they've got very severe pain and they cannot elevate their arm. And within 1 to 2 treatments, we've changed that dramatically, and the pain does not come back. We've also treated many hernias with patients who've had chronic pain from that, total knee replacement, elbow, sesamoidectomies, bunionectomies, etc. And then with cancers, we've had patients with nerve compression syndrome. So we've been enabled to find the nerve that's responsible and treat that region. Also persistent idiopathic facial pain, post-dental treatment, where there may be some trigeminal nerve disturbance. And that is very, very effective. Degenerative spinal disease, we would treat close to the facet joints. We would then also treat if there's referred pain down the sciatic nerve. It might be posterior or lateral. In failed back syndromes, it can be very successful to treat the sciatic nerve in the gluteus region. We treat chronic thoracic pain, which is a very difficult condition to treat. We might treat it at the spine or in between the ribs so that we could find the thoracic nerves. We've also treated, very interestingly, vestibular conditions creating dizziness and nausea, especially in the elderly. And we treat at the auricular nerve and even at the occipital nerve right up at C2. We've also been able to treat perineum pain, where we've treated the ilioinguinal nerve and we've treated the pudendal nerve. There we've treated the patient with the pudendal nerve where they lie on their side and they lift their knee and their hip, and then we get as close, we find the sciatic nerve, and then we move closer to the sacrum to get that effect. You can also treat the tibial nerve in the leg. You can treat it on the medial aspect of the leg because that reaches the coccygeal plexus. Treating post-stroke spasticity, it enables more mobility for the patient. What we've done is, let's say the patient is very spastic on the forearm, so then we would actually go and treat the muscle, and you'll find that the spasticity releases, and then you can do mobilization. We treat most injuries, joint pain or stiffness, where we go to the plexus, for instance, the brachial plexus. We've also treated patients who've had inability to void urine, and so we've treated the pudendal nerve and the tibial nerve. Of course, we've treated Bell's palsy, and we've also treated patients with post-acoustic neuroma, where we've had to treat for quite a long time, maybe 6 months, but the patient has got restoration in the facial muscles. We've also had post-radiation for cancer of the mouth, so we've treated the buccal, parotid gland, as it comes out. And throat cancers, we've also treated patients treating the various nerves that are related to it. And we've treated xerostomia from radiation and compression of the perineal nerve in the leg, and also long thoracic nerve injury. So we've treated many, many different types of conditions and have seen very good results.
Fantastic. Thank you for that, Phyllis. We had a question here. Let me just find it quickly with regards to post-shingles pain. So yes. What is your comment on that?
Yes, treated many patients with that, just depending on the nerve, if it's trigeminal or it's occipital nerve or thoracic. Then you would go to the nerve supply as it emanates from the spine, treat that area, and then treat along the pathway of the offending area, and you will get very good results. I think it's best to start with the spinal area first, because then you won't get irritation, and then see how the patient responds.
All right. Can you tell us a little bit about that, the potential for irritation of a nerve? And
yes. Very often a patient, well, not often actually, sometimes a patient will get increased pain after treatment, and then it's a good idea to wait a week and see if that pain dissipates, because it might be a good pain. Sometimes as a nerve recovers, it becomes more sensitive, and so it doesn't necessarily mean that you harmed the patient in any way. Just give time for the nerve to recover, and then afterwards you might be able to evaluate and see if some of those symptoms have actually improved. And sometimes it's not even the pain that's improved, but it's the numbness and the tingling and burning sensation that's improved, but the pain may still be there. So it's worthwhile continuing with continuing the treatment.
Excellent, thank you. Have you had any drop foot patients?
Yes, we have, and they do respond very well. Depends on what's happened. If there's been a complete axonognesis where they've cut the nerve completely, then you will not get change, or it might take a very long time for the nerve to grow. And when it starts to grow, you can activate the nerve. But when it's a neuropraxia with axonal degeneration, then you definitely will get improvement. Well, we've had a patient for all the muscles, in fact.
Excellent, excellent. Can you tell us a little bit about one or two of the cases that you had the most dramatic effect on?
Gosh, okay. We've had
I know there's been so many.
I think what excites me most is the complex regional pain patients, because they have struggled for a very long time with chronic pain, and there we see dramatic results. You can expect to see results within 3 treatments. You might not have complete resolution of pain, but you should start seeing your visual analog scale score reducing. So you'll see that within at least 3 treatments, and then you may have to go on to another 3. But you know, with a complex regional pain, they're very sensitive to touch. So you can't actually go in and touch the local area. But as soon as that pain has diminished, you can start to treat the patient. And the beauty of this is that we need to treat the actual area where the injury has occurred, because we know that there may be a minimal injury involved in complex regional pain syndromes. It's a minimal injury, but because you can't go in and treat the thing, you can't heal it. But once the pain is diminished, you can actually go and use other forms of treatment, and it will then resolve. And also the good thing about it is once the pain starts to resolve, patients will start to move, improve their mobility. And once they improve mobility, circulation improves, and then you're going to get improved movement as well as pain relief. And in fact, that helps your rehabilitation. And I must say that I think that should be the treatment of choice for patients like that. And if the patient is very sensitive, you would go to the nerve supply in the spine. You might go to L23 or L45 or L5S1 and follow the sciatic nerve down and see if it has an impact on the nerve problem that you have.
Excellent. Thank you, Phyllis. Can you tell us a little bit about the frequency of treatment? Obviously, as we've seen with very severe motor damage, like in the case of Bell's palsy, we've had some therapists treating people every day.
Yes, you can. With Bell's palsy, you certainly can, because you want to get that nerve supply activated as soon as possible. And I would suggest that. So I would do, you don't need many treatments. If the patient comes fairly quickly, within 10 days to 2 weeks of the diagnosis, and they've had their medication, you don't ask a patient to stop taking medication. They must have their medication, which is antivirals and sometimes cortisone. Then you can treat the patient daily, and within 4 to 5 days, that patient should be resolved. If it's a more difficult problem where you've got a viral problem that doesn't resolve, it will just take longer. But then you can drop the treatment to twice a week or once a week as soon as you see resolution.
Great. So Gregory is asking us, he says, if you treat your patient only once per month, will it still help the patient? Just take a longer time to improve? Yes. What is your opinion? I mean, obviously, I think it will be quite patient specific and yes, depending on what's wrong with the nerve.
Well, you know what I would say? I would only do something like that once a month if I've already cured my patients, where they've settled down and they're very much better with, for instance, twice weekly, or once a week till you've done at least 6 treatments for a difficult condition. But as I say, within 3 treatments, some patients don't need any further treatment. But let's say you've treated the patient and they have a relapse, then you can see them once a month, possibly to prevent it, especially with headaches. Headaches are highly responsive to Stimpod, and you get different kinds of headaches, and I'd like to go into it and put it on the web, because we've got migraines, we've got tension type, we've got many different types of headaches that I'd like to explain how you would treat, and I'll do that on your...
Definitely. Well, we've had a couple of requests now for a protocol on that, so that will probably be the next one that we'll target. Fantastic. Thank you very much. Phyllis, shall we do a physical session quickly?
Yes.
So one of the studies that Phyllis is doing currently is with regards to diabetic neuropathy. Could you just tell us a little bit about the study? I mean, it's not sharing things we're not allowed to share, but...
Yes. Yes, we're doing a research project. We're hoping to treat 80 patients. It's a randomized controlled trial, and we have a placebo arm. And we are treating the patient in a very interesting region. It's for diabetic neuropathy in the feet. And we're treating the patient at the sciatic nerve before it bifurcates at the posterior knee crease. So each patient will get 10 minutes of treatment, or not, on both legs, both bilaterally, and we'll treat them once a week for 3 weeks, and then we will see them 1 month after the last treatment, 3 months and 6 months, and reevaluate them for for the study.
Okay, excellent, and that's exactly the same protocol that was done in the UK at the St Thomas's Spain Hospital, that we've already published on the website, the results of the pilot study.
I actually made contact with Gorozenik, and he explained to me that was where he actually treated the patients, and he only treated them 3 times for 5 minutes each at that same region, and he had no negative results. So we decided that we were going to test out his protocol, and that's why we chose that region to treat.
All right. Excellent. Oh, yeah, another interesting question is asking, how does a Stimpod compare with a scrambler? I don't know. Are you familiar with a scrambler?
No, I'm not sure. You know, my specific interest is electrical current. Could you tell me what type of current that would be? Is it a direct current, or is it a type of TENS where it's an alternating current? Or is it a combination of TENS currents?
If you could perhaps send us an email, we'll just look into it, and I'll also look into the scrambler and see exactly what it is, and I could possibly tell you what the difference would be. And then the second question is Stimpod results between diabetic neuropathy and idiopathic neuropathy.
Well, we can't give you that at the moment, but we have had good results with both. I think that polyneuropathies are difficult to treat because sometimes we don't have the full diagnosis. But also you have patients who've had post-chemotherapy, and they do have a lot of neuropathy, and these patients are the ones that would respond very nicely to this treatment, plus acupuncture. In fact, it's a very good idea to combine your treatments with other things. So I do suggest that's helpful.
Right, excellent. Patients with screws and rods in the spine, what is your
No problem whatsoever. We've done many patients with failed backs and with that type of surgery.
Yeah. I think the key there would be, you know, as long as the metal aspects are far away from the nerves, then if it touches the nerve, it could concentrate the current to the nerve. But the current is also of such a nature that you'll see the patient responding.
And we don't see the patient straight away. We see them many months down the line where there's fusion and extra bony growth around. So.
Exactly. There's a question about a spinal cord stimulator. I have to tell you that that is a contraindication. Any implantable electronics at this point in time is a contraindication. So that's all we can say about that. So, yeah, another question. Do you treat most patients while seated? Do you have any treatment room setup recommendations?
Well, very often we do treat a patient who's seated who's in such pain that they cannot move too easily to go onto the bed. Then we would treat them seated, usually brachial plexus or headaches or an arm. But when it's in other areas, we would treat them lying on the bed, either prone, side lying, or in any comfortable position that they would be best.
Excellent. All right. Okay, let's see, laminectomies, metatarsal spinal pain.
Yes, those patients we treat, you'd go right to the level that's involved, and then you would treat it at the facet joint, and you would treat bilaterally, because sometimes we don't actually know where the pain is coming from, whether it's coming from the left or the right side. So it's a good idea with any kind of lumbar degenerative pain to treat bilaterally on either side, on each facet joint. And in fact, it's a good idea to start at L2-3, because sometimes pain actually comes from higher levels than what we actually think that we see on the X-ray. Facet joint.
Excellent. All right, thank you. Great. I think let's get busy and let's do a quick demonstration. We anticipated to have this webinar for about an hour. We've got about 20 minutes left. So I think if we do a quick demonstration of your diabetic neuropathy.
Yes.
So we'll do the setup and locate the point, show you the fasciculation, and then if you have any more questions, please post it, and we'll come back to the desktop, and we'll see how many of those questions we can answer. We're going to switch now to a different camera and a different audio feed.
Okay. So for treating diabetic neuropathy, and especially in the study, we use what's called we call it the indifferent electrode. You call it the
reference electrode,
reference
or the
electrode,
grounding pad.
The grounding pad. So
yeah.
we like to use it on the opposite side of the body, because we know then that we won't be translating the current from the probe, which you can see here, to the grounding electrode. Yeah. And so, I'm going to come.
Sorry, if I can just interject, adding to what Phyllis just mentioned, the closer, if this was on the same side, it wouldn't really matter that much. But the closer it is, the more superficial the current is on the skin, and you don't really get the depth. If it's on the other side, then this approaches the same physics as a point source, and it will radiate very evenly downwards. So we get better depth and better penetration. Another option would be to put the grounding pad on the opposite side and force the current right through. So sometimes we use the placement of this strategically in difficult to reach nerves, but for this purpose, if you just put it contralaterally, you get a very even spread of the electrical current and the electromagnetic field into the person. All right.
Okay. I'm now going to put some gel where I believe I will pick up the nerve. So, and here is the probe, and I'm going to find the spot in this area, because this is what we have been doing for the protocol. I'm going to switch on the device, and as soon as it comes on, we usually use it on 0.2 millisieverts and on 2 hertz. So I'm going to turn up the current, and I'm going to ask Larry when he feels a sensation. So this is how we do it. And you can hear the pulsation. You can hear the beeping sound.
Starting to feel it.
You're starting to feel it.
Yep.
And we may be able to see on the foot already. Can you see some movement?
I can see it, yeah.
See it. Now, it's on 13 milliamps. So I'm going to just move around to make sure. There we are.
What's the pulse width?
The pulse
0.2 milliseconds. All right.
Actually, I was a little bit too high to start. So now you can see that at 13 milliamps, I've now got quite a strong fasciculation in the leg, and it's generalized. You can see it's the whole nerve supply. And you suggest that, well, you say 0.2, and I could go up. Would you like me to go very much stronger?
Yeah, how does it feel?
Could I manage? Now that's at the maximum strength of 30. And is that too strong for you?
That's a little bit uncomfortable.
Okay, so I'm going to reduce it. And you can see I've got a very firm pressure. Now, if this patient was very severely affected, the pulse would be very weak. And each time I come to treat the patient, if there's improvement in symptoms, the pulse will get stronger, and I'll be able to reduce my current intensity to get that same increased pulse.
Contraction, fasciculation.
Yeah.
Okay.
Yes, I would.
All right.
So that would give me...
So even though we're treating the painful aspect of the diabetic neuropathy, we're also improving the conduction and the motor aspect of the diabetic neuropathy. That's what you're saying. That's what you're seeing.
And the interesting thing, it improves walking ability. I've noticed with some of the patients in the study that those that were sort of dragging their feet are walking, lifting their feet with much more ease. They seem to have less numbness and tingling and burning and paresthesia. So that's very interesting symptoms to dissipate if possible in these patients.
Now, Phyllis, I noticed that while that the protocol that you had given us when we were busy with it, with the publishing, I noticed that you mentioned that we start with this obviously because the sciatic nerve innervates basically the whole lower leg. And that's why we get a very good contraction of the calf muscle, the foot, just about everything. Once the pain starts dissipating, is it that the pain can become more localized?
Yes, now that's a very good point, because we're only doing this particular treatment here because it's a research project. But once the pain gets very much easier, then I would definitely go much more local. And what I would do is I would, depending on where the discomfort was, it's usually underneath the foot and the sole of the foot and the top of the foot. But for instance, let's say it's more lateral, I would try and pick up my my perineal nerves in this region, and I'm going to look for it to see if I can pick this up.
There we go.
There you are.
Great.
And you can see that's the circulation. And I would use it in the medial region, and also very importantly, I would use it on the sole of the foot. And I'm going to demonstrate that to you right now. I'm going to reduce the current. And then I'm going to go onto the sole of the foot. Now, I don't recommend starting it on the sole of the foot because these are the patients that when brushing or touching are very sensitive.
Very allergenic.
So I'm going to go to the sole of the foot, and I'm just going to ask Yuri how it is. How's that?
Can't feel anything.
Most patients, because the skin is so thick, you feel it now on 19 milliamps, but I can't see very much. I'd like you to see what happens now.
Okay, I can see fasciculation all the way up into the ankle.
Yes, it moves right up, but also it will move the toes. And also, if you don't get a very good contraction on the sole of the foot, you can start moving medially. Now we're moving it. Can you see the toes?
Unfortunately, I don't think our camera covers the toes at the moment.
Can you bend your knee for me? Can you see that?
Right, there we go. Okay, fantastic.
Yes, thank you very much.
Great, thank you.
So once you understand the anatomy of the nerves, then you can follow any of the nerve supply that you think is involved in the particular region for the patient in any form of condition that you want to treat.
Excellent, thank you so much. So it seems very simple.
Very simple.
So the device is very straightforward, very simple to use. Was it very uncomfortable, though?
Not at all.
Not uncomfortable at all, and you actually took it all the way to the maximum.
Yes.
It's a very pleasant experience.
I will mention that those patients with diabetic neuropathy always say, "Ooh, I like the sensation." They like that knocking sensation because
there is a square wave that facilitates the fasciculation, and the square wave is actually designed in a way that has got a very sharp edge, specifically to be able to differentiate between a nerve that is normal, because in a normal activated nerve that will feel prickly. And we often get that feedback from people that feels prickly, but like you mentioned now, we've often seen and gotten feedback from patients and many therapists that patients claim that when a nerve suffering from neuropathic pain is treated, that it's actually extremely comfortable.
Yes.
But then as it heals, that it starts becoming more prickly.
Yes.
Right.
Like an amputation, actually. The nerve has been damaged, and then as the nerve starts to recover, you get more sensation, and it can be uncomfortable at first, and then it eases up, actually.
Exactly.
Yes.
Exactly. Fantastic. Phyllis, thank you very much. I think let's move back to the desktop, and then we'll answer some questions if there are any questions remaining. We'll see how much time we have left. Thank you so much for that. All right, I see a couple more questions that popped up, and we have a couple more minutes left, so let's see what we can answer. Right, has it been used for phantom limb pain? Have you had any patients like that?
I have not treated anyone for phantom limb pain in my practice, but I'm sure that it would be extremely useful. And then you would use the main nerve supply, femoral nerve, sciatic nerve.
Excellent. Have we considered a patient info brochure? Terry, thank you for that question. You know, we are actually pursuing that at the moment. We will have a patient section on our website, so as well as the therapist side, to provide more clinical information. But thank you for that suggestion. How much would you charge cash paying patients? Now, we have a little article on the website with regards to which codes can be used and suggestions for how you should charge. That's really a difficult question for us to answer, being based in South Africa. But we have consulted with actually the gentleman who wrote the article is one of our clinical advisors in the US. He's a chiropractor, or Dr. Stuart Humberg. So you're welcome to have a look at the article. If you don't feel it's sufficient, please send us an email with specific questions so we can elaborate on that, and we'll consult with the correct people in the US to assist with that. Okay. I think those are all the questions. Are there any? If there are no further questions, I think this is a good place to stop the webinar. We thank you very much for attending. I hope it was informative. We do intend to do a lot more of these. They will be more specific with regards to protocols, different subjects, perhaps. You know, just one specifically on neuropathic pain, nociceptive pain, the different types of pain, how to diagnose it, how to know for sure that you've got the right nerve. So those are a bunch of subjects that we anticipate to have in future. We'll also do one specifically on radio frequency technology, just to explain to you a little better with regards to the technology behind the device. It's a big pleasure. I'm glad many people found it very helpful. Please don't hesitate to contact us. Thank you very much.
Thank you.
Thank you very much, Phyllis, for your time.
You're welcome.
It was really great to have you here. Really appreciate it. Thank you.